Okay. Some notes. Some notes in regard to, in regard to, in regard in regard to sickle cell anemia, sort of awareness, and and also uh, in line with sort of Biomedical Science Day 2023, and also in line with blood blood donor day 2023 as well. This sort of record and this sort of the these notes are in regard to some peer reviewed publications around sort of aligned to blood transfusion and sickle cell anemia, and uh, 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 in line with sickle cell anemia and thalassaemia, and in line with hematology and transfusion. Uh, um, so by Ramona and team, Ramona and team from in Ramona and team in works published in 2020 in the journal Patient Experience, looking at blood transfusion knowledge perspectives and experience of individuals with sickle cell disease. The in around sickle cell disease, or SCD, it's a genetic blood disorder that frequently leads to complications, and the complications can be linked to extreme pain, organ damage, and pulmonary complications that may affect physical and sort of psychosocial well-being. It is estimated that up to in around up to 100,000 Americans have SCD in the United States. In the states, SCD is most prevalent in amongst African Americans. Sickle cell disease occurs in about one in every 365 African American births, compared with one in every 16,300 Hispanic births, and one in every 100,000 non-Hispanic and one in every 100,000 non-Hispanic white births. Under certain conditions, individuals with SCD, sickle cell disease, may require blood transfusion or a series of blood transfusions, and these may be episodic or for treatment of acute, potentially life-threatening disease complications. For some individuals, a program of regularly scheduled and often lifelong chronic transfusion is optimal primary treatment for disease. Despite its therapeutic nature, blood transfusion carries its own risk of significant, potentially life-threatening complications. The most concerning of these is red cell alloimmunization, where alloimmunization is linked to where the immune system of a host, the immune system of the host of host cells attack post transfusion after recipient has had a transfusion, and the immune system, and where the immune system causes lymphocyte or leukocyte migration to lymphocyte or leukocyte migration of white cells or T cells, in particular cells aligned to CD8, for example, to attack cells parts of other cells and the immune system, other parts of the immune system post transfusion, or where a recipient has received a transfusion, which can delay and wherein alloimmunization can cause delayed hemolytic transfusion reaction upon subsequent transfusion, and iron and also iron overload. The complications can be prevented, minimized, or managed when patients and providers follow practices. Follow practices such as those have been in this paper by Ramona and team from 2020, where sort of practices had been published in 2014 by the National Institutes of Health, National Heart, Lung and Blood Institute. The cause of preventable transfusion-associated complications are numerous and often occur because adherence to disease management transfusion practices is inconsistent. Also, there is currently no unified or in unison sort of system that provides ongoing statewide education to health service providers. So this paper, this peer-reviewed publication by Ramona and team from 2020, published in the Journal of Patient Experience, highlight again sort of knowledge, perspectives, and experience with individuals with sickle cell, and in this works 22 participants were recruited from 2 comprehensive sickle cell disease treatment centers in Georgia, United States, and interviewed regarding knowledge about transfusion and potential complications, attitudes about data storage and sharing, and transfusion experience. Participants had general knowledge of, for example, in around physiology, blood products, and blood transfusion, including the risk of complications, but varied in comprehension of complex health information and level of misinformation. Patients also varied in preferences for how they would like transfusion information stored. They saw both in this peer review works. They saw both advantages and disadvantages to wallet cards, smartphone applications, and data registries. And there is Ramona and team in this works had identified there is a requirement for patient-centered approach that involves transfusion education and shared decision making. Education should range from essential and simple to more in depth to accommodate varying education and comprehension levels. In the peer review works, as part of the in this works, as part of the methodology. There is overview in regard to the setting, and context, how participants were included and recruited, in regard to the interview procedure during the investigation, and also in line to reflexivity, and in line to data analysis. There is an overview in regard to the varying themes. For example, patient knowledge. One of the themes in this works For example, patient knowledge of transfusion and potential complications, patient attitudes and preferences about ways to store and share transfusion history, patient perspectives on transfusion experience, and in around the sort of corresponding themes. Corresponding themes included basic knowledge, varying comprehension and utilization of complex health information, advantages, drawbacks for any method or methodology of storage, generational differences in preference and privacy concerns, and also unpleasant but helpful in line to corresponding themes, and in the as part of the sort of main themes and corresponding themes, that also some the authors have highlighted a few exemplary quotes from the research from the research that took place in this peer review publication. There is also some information in regard to knowledge about transfusion and potential complications, and attitudes about transfusion history and history, storage and sharing, perspectives on the transfusion experience, this part of the discussion in the peer reviewed works, the blood management strategies call for a multidisciplinary approach and a patient-centered approach to address adult SCD patient requirements. The National Heart and Lung and Blood Institute in 2000 and 2014 expert panel report recommend that service providers obtain an accurate transfusion history, including locations of previous transfusion and any previous adverse effects. And that same in this works, in this works, as part of this works, the authors highlight is critically necessary that patients are educated and empowered and have ability and all capacity to communicate in around sickle cell disease regarding history or related history, as well as any blood transfusion relating history. The limitations around this particular investigation, the authors inform the patients. Although interviews were continued until no substantially new information was identified, the sample size was small and may not encompass a full range of knowledge, attitudes, and experiences of sickle cell disease patients regarding therapeutic blood transfusion. Blood transfusion. This is especially especially true given that all participants that participated at comprehensive SCD centers, it is possible that they may be more trusting or differential toward service providers whom they know are leading specialists in around SCD. Patients living in areas without such specialists might have greater urgency to educate themselves educate themselves on the disease, have different attitudes about data storage, and may have had different experiences whilst receiving transfusions. The research. The peer review publication highlights that the peer review publication has also has a list of references and related from related authors in around this works. At the same time, in regard to this peer-reviewed works, peer-reviewed works around blood transfusion knowledge, perspectives, and experience of individuals with sickle cell disease or SCD by Ramona and team from 2020. Works by Tang and team from Tang and team in their works by Tang and team from their works in 2022, published in the journal of the journal of blood of pediatric blood and cancer, and works by Tang and team look at trends in blood transfusion, hydroxyurea use, and iron overload amongst children with sickle cell disease (SCD) enrolled in Medicaid between 2004 and 2019. The works, this peer review works, by Tang and team from the Aflac Cancer and Blood Disorder Centers Children's Healthcare of Atlanta, Georgia, United States. The team look at conducted a serial cross-sectional cohort investigation of pediatric sickle cell disease patients from 2004 to 2019 using Georgia Medicaid claims data, and for each year, the authors reported receipt of any transfusion, chronic transfusion, or three or more failed hydroxyurea prescriptions. For children or peds receiving chronic transfusion, six or more annual transfusion, the authors evaluated iron overload diagnoses, monitoring, and chelation use among children with sickle cell anemia SCA. The authors examined rates of transfusion and hydroxyurea use, and the authors use something that's referred to as the Cochrane Armitage test to assess trends. This works, there were 5,316 unique children between ages 2 years and 18 years of age with sickle cell disease enrolled in Georgia Medicaid from 2004 to 2019. Children receiving any transfusion children receiving any transfusion increased from 2004 to 2010, then stabilized. In sickle cell anemia patients, chronic transfusion initially increased from 2004 to 2010, then stabilized from 2010 to 2019. For chronically transfused children, monitoring of iron burden and field chelator prescriptions both increased significantly. Hydroxyurea use in sickle cell anemia patients increased from 12% to 37%, with increases noted within each age group, most notably from 21% to 60% in the 13 to 18-year-old cohort. The authors in this works highlight again that sickle cell disease or SCD, and is a complex chronic genetic disorder in which the presence of abnormal sickle cell hemoglobin or HbS in red cells causes varying degrees of hemolysis, anemia, and progressive vascular injury. The clinical severity of SCD varies among individuals in part based on different SCD genotypes or phenotypes, and those with sickle cell anemia SCA genotypes homozygous HB and HBSS and HBS beta 0 thalassaemia generally have more severe anemia and higher risk for severe complications than those with other SCD genotypes. For example, HBSC and HBS beta positive beta plus or beta positive thalassaemia, packed red blood cells or PRBC transfusions are an effective therapy for many SCD complications. Transfusion may be episodically for acute complications such as acute chest syndrome or acute stroke or chronic transfusion. Thereby, therapy or chronic transfusion therapy may be used for other indications such as primary or secondary stroke prevention. PRBC transfusions reduce the severity of anemia and decrease the relative percentage of circulating erythrocyte containing HbS, reducing vascular occlusion and improving blood viscosity. They can be administered. Treatment PRBCs packed red blood cells or PRBCs can be administered through simple transfusion, partial manual exchange or PME, or automated red blood cell exchange or RCE, also termed as erythrocyte The mode of transfusion depends really on a number of factors, including transfusion indication, planned duration of therapy, and available vascular access. In the peer review works, the authors describe the demographic characteristics of the study subjects by total population and subpopulation in pediatrics, in pediatric child years from 2014 to 2019. The demographic characteristics go from are highlighted by the authors in this works are from ages 2 years of age to 18 years. The total number of participants in context of demographics between two years of age to 6 years was 10,685. Between 7 to 12 years of age, 12,308, and between 13 to 18 years, 11,240 was a total different totals of peds or children or peds with sickle cell disease. At the same time, the authors have authors highlight the highlight that highlight there's a predominance in females versus males with sickle cell disease between 2004 and 2019. The authors in this peer review work highlight aligned with the demographic characteristics with the demographic characteristic and the total number of participants by total population and subpopulation in child years was 34,233. Those who were ever transfused. Those that were ever transfused was 5,085, and those who were chronically transfused were 1,795. In this peer review works, the authors also highlight SCD care utilization by study subjects by year 2004 to 2019, total population and subpopulation of children chronically transfused, and where the authors highlight sort of the highlight in context around between 2004 and 2019 information in regard to the total number of children or peds total number of peds or children that had at least one transfusion, had more than three specific treatment prescriptions filled, had chronic transfusion where there were more than six transfusions that took place in any one child peds or children between 2004 and 2019, and the total the authors highlight in as well the total chronic those peds children or peds the children and peds total chronically transfused, iron burden, the iron burden assessed, iron overload and chelator assessed, iron overload diagnoses, and at least one chelator prescription, chelator prescription filled, and the authors highlight that as part of the discussion in the peer review works, the authors highlight that in this investigation, the evaluation of peds or children or peds with sickle cell disease patients enrolled in Medicaid in Georgia over a 16-year 16-year duration from 2004 to 2019, there were notable trends in transfusion practices, hydroxyurea utilization, and iron overload monitoring that followed several main updates in sickle cell disease management guidelines, in the cohort, between 33 and 38% of sickle cell anemia patients had three or more filled hydroxyurea prescriptions per year for previous 5 years of the investigation from 2015 to 2019, and this was an increase from the 12% noted in 2004 and the first study year hydroxyurea this was an increase from 12% noted in 2000. In 2004, in 2004 from the first study year, hydroxyurea uptake increased with age, suggesting that patients and healthcare service providers may be more likely to initiate hydroxyurea as patients develop more clinical manifestations of sickle cell anemia. In around the main around the sort of the main sort of in around the sort of main summary of this peer review works by Tang and team from 2022, published in Pediatric Blood and Cancer. The authors highlighted that an overall increase in iron burden assessment was identified. Iron overload management and hydroxyurea utilized in peds with sickle cell disease patients from 2004 and 2019 had been identified, and blood transfusion rates showed an initial increase from 2004 to 2010, followed by an overall stabilization between 2010 and 2019. These trends largely tracked with the publication of pivotal investigations and national guidelines over the 16 years, reflecting important changes in clinical management of sickle cell disease patients in primary and secondary disease prevention and disease modifying therapy, and advances in the inability to monitor for and treat iron overload in chronically transfused patients. The team highlight that further investigation should explore factors that contribute to differences in healthcare utilization and care outcomes amongst SCD sickle cell disease patients, and how to best translate and accelerate the adoption and the adaptation of advances gained in through clinical trials to the general sickle cell disease patient population. This peer review works has references or citations with similar related published works. Another paper published in 2022 in Frontiers in Medicine by Patterson and team in 2022, where the authors look at transfusion complications in thalassaemia and look at patient knowledge and perspectives. The authors highlight that chronic transfusion used to manage clinically significant forms of thalassemia carries complication risks, including iron overload, alloimmunization, and allergic or hemolytic reactions. Dissemination and implementation of evidence-based guidelines for minimizing these risks are complicated by the small numbers and increasing dispersion of the thalassemia population. This elevates patients' role in understanding and communicating with healthcare service providers about treatment. The present study, the authors in this investigation sought to assess thalassemia patient knowledge of transfusion complications and guidelines, and the experience of clinicians following guidelines and perspectives on ways to store and share personal transfusion data. In this works by Patterson and team from 2022 in Frontiers in Medicine. In Frontiers, a sample of 32 patients participated in structured interviews. Most if not all participants understood iron overload, chelation therapy, blood typing, and cross-matching. Awareness of each of the five of evidence-based transfusion guidelines that were discussed range from 72 to 82%, 88 range from 72 to 88%. Patients expressed privacy concerns about each of the three data storage options. Slightly less for data through specific data registries than for a wallet card or a smartphone app. The data registry also avoided concerns that other options placed extra burden on patients. Recommendations by authors include increased education on the meaning of significance of packed washed red blood cells, leukoreduction, and detailed cross-matching, and implementation of a nationwide data registry to make transfusion data available to healthcare service providers anywhere at the point of care. Data registry implementation should be sensitive to patients' privacy and security concerns, but also help them appropriate weigh those against safety advantages. The authors highlight that the actions could help reduce transfusion complications in thalassemia by improving patient efficacy and including adherence to evidence-based guidelines. The authors in this work informed thalassemia describes a group of inherited blood disorders associated with the alpha and beta globulins of hemoglobin. Alpha thalassemia and beta thalassemia result from the reduction of either alpha or beta globulins, or accordingly both types of thalassemia result in moderate to severe anemia and extramedullary hematopoiesis, leading to signs and symptoms such as poor growth and development, skeletal deformities, thrombosis, pain in head, back and legs, impaired cardiac function, hepatosplenomegaly, non-transfusion iron overload, and conditions such as high drops fetalis. It is estimated that 300 in the peer review works. The authors highlight that it is estimated that 300,000 to 400,000 neonates are born worldwide with hemoglobinopathies, with approximately 23,000 per year characterized as thalassemia major, the most severe form of thalassemia. Those cases of thalassemia worldwide typically concentrate around thalassemia, concentrate around where the authors in this works refer to something that is called a thalassemia belt, and immigration into the United States from Italy, Greece, Pakistan, Iran, India, and particularly Central and Southeast Asian countries has markedly increased the prevalence of thalassemia in the country. Alpha thalassemia major is often incompatible with life. In cases of severe anemia in beta thalassemia major, individuals are usually diagnosed within the first 2 years of life and may survive with chronic lifelong blood transfusions. Unfortunately, transfusions have risks and complications, iron overload and resulting endocrine complication, erythrocyte alloimmunization, transfusion reactions, and infections are all risks of thalassemia patients who are depending on blood transfusions. These complications, however, are largely preventable if patients or recipients know personal transfusion history, for example, and are aware of the main clinical practices and practice and sort of recommendations. They can contribute to reducing the complication risk through actions and through communications with healthcare service providers. This in this works, the peer review works, the authors looked to had looked to collect data in context of a descriptive investigation, a descriptive investigation from individuals with thalassemia in the United States who had received therapeutic transfusions. At the same time, the authors carried out structured interviews, included questions eliciting participants' knowledge and experience in around transfusions, and experience in around healthcare service providers, performance of main actions, actions recommending in applicable and through applicable guidelines and published by, for example, the Thalassaemia International Federation, and preferences and feedback regarding possible ways to store and share personal transfusional based data. The authors in this work recruited participants where the inclusion criteria included included participants who had a diagnosis in around thalassemia, being at least in the ages of 13 years of age, and having received at least one blood transfusion as a treatment for thalassemia. And the criteria were chosen to capture a wide range of participants who could reflect on and communicate experiences. As part of the recruitment process in around this works by Patterson and team in 2022, the recruitment, a Cooley's Anaemia Foundation, a nationwide thalassaemia patient advocacy group assisted in recruiting participants, in recruiting participants, and a convenient sample of participants meeting the main inclusion criteria. The Cooley's Anaemia Foundation shared the approved recruitment shared an approved recruitment flyer through its social media platform and email database. Intrigued individuals followed an embedded URL to an online form where they provided availability and contact information. A researcher from the peer reviewed from the authors in this peer reviewed works provided followed up to schedule an interview at a mutually convenient time. Consent was obtained at the time through a telephone interview, and the participant was if the participant in this works, if the participant was a minor other than 13 years of age or younger, a parent or guardian was required to be present for the interview and provide consent. While assent was obtained from the minor. Participants also were partially incentivized in part of this as part of this investigation, in part of this research, this investigation research. In around the analysis, around the analysis around this works, specifically the analysis followed 5 steps. Number 1, to create a neutral domain name corresponding to each interview question. Number 2, to create a summary template for the use by the team. Number 3, to assess the summary template. Number 4, establish consistency in template use across the team. And 5, transfer summaries into matrix with rows for each respondent and columns for each domain to synthesize results. In around the authors also developed a short domain names corresponding to each interview question. So, for example, one question, what information have you been given about transfusions, was represented by the domain name transfusion information received. Next, in following an interview summary template was drafted to include each domain name, and team members used this template to code an initial set of transcripts. The team met to determine whether the domain names were intuitive, accurate, and complete, and to assess the ease of use of the template and length of time required, and to reach consensus on guidelines for consistent coding and template use. For example, and the type and length of quotes or quotations to include were on the form on a templated form. Finally, the authors coded the sort of remaining transcripts and data and compiled the results into a single document for synthesis. Results were summarized for each domain, and noting both general and unique responses to reflect the breadth of perspectives and experience across the cohort, across the research cohort. In around the sort of main in around this peer review works in around the result in around this works highlights contextualizes the transfusion experience, the transfusion experiences, contextualizes information that's contextualized with the frequency and context of the number of transfusions recipients have received, in around blood typing and cross matching, and also the duration in around treatment and sort of how participants recruited in this investigation spend time as part of their blood transfusions, and the authors highlight some context in around the sort of complications around treatment as described by some participants, and in around the authors also highlight some data in regard to the knowledge of transfusion and recommendations, and also where in around this work, the authors also highlight perspectives on data tracking approaches, and highlight in around highlight transfusion complications and practice guidelines, and in around some of the limitations. Thalassaemia is a rare disorder with a relatively small patient population in the United States, while the present sample included individuals from multiple regions of the country, from both high and low population density areas. Its size limits in context of participants that were recruited limits its representativeness of the overall study population. The absence of demographic data precludes characterization of the sample as representative across race, ethnicity, gender, and age. And because the thalassemia population in the United States includes both multi-generation Americans, both recent immigrants from a wide range of countries, and the English proficiency of the current sample may introduce a bias as well. The authors highlight, despite the limitations, the range of responses and the convergent and divergent aspects offer findings or analyses that may be useful as a starting point for prospective investigations, prospective investigations or pilot interventions. In around the sort of main conclusions, the authors highlight that the authors highlight that the highlight in the main that a dissemination and implementation strategy for best practices and clinical guidelines, particularly in the case of rare disease such as thalassemia, would do well to include parallel and patient-focused strategies. Again, this peer review works again has references that have works that are published works in around similar relating published works as as well. In around works that looks at transfusion. In another paper, peer review works published in Transfusion Medicine, works that looks at transfusion service knowledge and immunohematological practice relating to sickle cell disease and thalassaemia. Authors Fasano and team look at look to assess current knowledge of National Heart and Lung Blood Institutes and Thalassaemia International Federation recommendations, blood banking practices, and perceived challenges among transfusion services in the blood management of patients with hemoglobinopathies. In around a specific background of this peer review works published by Fasano and team in Transfusion Medicine. The specific background is where the authors look at how red blood cell transfusions are a main component of comprehensive management of patients with sickle cell disease and thalassaemia. However, they are not devoid of risk, and advances in transfusion practices or clinical care have led to improved safety and safety of transfusion therapy for patients with hemoglobinopathies with regard to transmission of bloodborne infections agents, red blood cell alloimmunization, transfusional iron overload, and suspected transfusion reactions. However, transfusion practices vary among healthcare service providers and transfusion services for patients. In around this peer-reviewed work, the methodology included where the authors implement a cross-sectional survey of transfusion services, aligned to transfusion services from the state of Georgia. Previously identified as having sickle cell disease or thalassaemia populations. The survey assessed transfusion service practices in pre-transfusion testing and and blood product selection, awareness, implementation of the National Heart and Lung and Blood Institutes, or NHLBI, and Thalassaemia International Federation, or TIF, transfusion-based recommendations and perceived challenges in transfusion hemoglobinopathy patients. The authors highlighted that previous surveys of blood bank medical directors, laboratory supervisors, and providers at comprehensive sickle cell disease, sickle cell, and thalassaemia treatment centers in the United States have demonstrated a lack of consistency on transfusion practices for sickle cell disease and thalassaemia. Over 10 years, over a decade ago, the results of a data set from a college of the American pathologists proficiency testing survey assessing over 1,100 transfusion service practices for non-allo-immunized sickle cell disease patients demonstrated that less than 30% of North American hospital transfusion service laboratories determine sickle cell disease patients based baseline red blood cell serological phenotype and beyond ABO and rhesus blood groups, and issued red blood cell units that were matched for rhesus big C, small c, big E, and small e, and KEL antigens and KEL antigens. More recently, although over a decade ago as well, Works by Dunbar and team in 2012 published results of a survey aimed at characterizing transfusion practices of sickle cell disease patients among hematology and oncology healthcare service providers within the state of Florida. The works by Dunbar and team in 2012 looked at a survey included adult and pediatric hematologists and oncologists of which non-academic and adult-orientated or focused clinicians represented a large portion of the respondents. The results again indicated a wide range of transfusion practices, and the majority of respondents did not routinely request phenotypically matched red blood cells for sickle cell disease patients until the patient demonstrated a new antibody. When compared to practices at comprehensive sickle cell centers, where more than 90% routinely provided rhesus, big C and small c, big E and small e matched and KEL antigen matched red blood cells. This highlighted significant inconsistencies in practices between comprehensive sickle cell centers and community-based healthcare systems. Furthermore, it had been previously shown that half of the thalassaemia treatment centers provided rhesus, big C, small c, big E, and small e matched and KEL matched red blood cells for transfusion in thalassaemia patients. As highlighted in works by Goss and team in 2014, and data also on transfusion practices at non-thalassaemia treatment centers and community-based institutions also currently or presently lacking. The authors in this work highlight in around the survey development, a team that included experts in pediatrics, adult hematology, transfusion medicine, and qualitative research, developed the questions and designed the survey for web-based software. The instrument was piloted. The instrument was piloted by other hematologists, and blood bank personnel from outside of the investigation's geographic scope. And the instrument is included in this peer review works by Fasano and team in transfusion medicine, published in 2019. The authors have an example of the survey in the main in the peer reviewed works as a supplemental information. The survey questions addressed covered respondent and institution characteristics and current practices in transfusion to hemoglobinopathy patients. Additional questions on training needs, training requirements, and preferred learning channels. Learning channels are not reported here, but were asked to inform follow-up activities. In the peer review works, there is the data analysis and the results. A total of 49 institutions were recruited for the survey, with 35 responding, around 71%. Multiple responses were received from staff at six institutions, and these cases And in these cases, the response of the most senior or highly trained individual by self-report was retained for analysis. Three responding institutions recorded providing no sickle cell disease or sickle cell disease or sickle cell sickle cell disease or thalassaemia transfusions, and three responding institutions reported providing no sickle cell disease or thalassaemia relating transfusions, and were also omitted from the analysis, including institutions represented 23 Georgia counties and three neighboring states, including Tennessee, Alabama, and South Carolina. And the three institutions were characterized as three institutions were characterized and additional descriptive data from the cohort are provided in the peer reviewed works. The authors describe in the peer-reviewed works in around the institutional characteristics and this peer review works by Fasano and team from 2019. The findings of the survey around the discussion, the findings of the survey provide insights into inconsistencies in transfusion practices for sickle cell disease and thalassaemia patients in a geographic region densely populated with these patient populations, similar to previously published reports. The authors highlight that the results highlight adherence to the NHLBI and TIF recommendations by sickle cell disease and thalassaemia treatment centers, where the authors highlight a variation in transfusion practices amongst other healthcare systems, and this may be due to unfamiliarity with recommendations. Alternatively, this may represent a reluctance to adapt to cost adding NHLBI or TIF recommendations due to a lack of high quality evidence supporting that universal implementation of red blood cell antigen matching transfusion protocols significantly impacts patient risk of hemolytic transfusion reactions, as highlighted in parts of this peer review works, but also by works by Fasano and team in 2018, and compared to sickle cell to other sickle cell traits. That all indicated that baseline red blood cell phenotyping for at least rhesus, big C, small c, big E, and small e, and KEL antigens is performed, and red blood cells are provided, which are matched up front. Before red blood cell before any red blood cell alloimmunization for rhesus, big C, small c, big E, small e, and K and big K. Over 25% of non sickle cell regarding institutions reported not to perform a red blood cell phenotype beyond generic ABO and rhesus and big D rhesus group beyond ABO grouping and rhesus grouping, or provide red blood cell units that are prophylactically matched for rhesus, big C or small c, big C or small c, big E, small e, and count antigens in accordance with NHLBI recommendations. And although this improved from a previous transfusion survey conducted over a decade ago from 2005 by works by Osby and Schulman in 2005, the results still highlight this works highlight significant gaps in adherence to transfusion recommendations in non sickle cell relating regarding community-based healthcare systems. Similarly, only 40%, around 40% of non-thalassemia reported non-thalassemia relating or regarding around 40% of non-thalassemia regarding or reporting obtaining red blood cell phenotype beyond ABO and rhesus group, and 80% failed to provide red blood cell unit prophylactically matched for rhesus, big C and small c, big E and small e, and KEL antigens in accordance with the thalassemia in regard to the Thalassaemia International Federation. With the Thalassaemia International Federation recommendations, as highlighted by works by Trumpeter and Cohen in 2014. Intriguingly, a subset of institutes described employing unit age and or irradiation restrictions for sickle cell disease and thalassemia patients in absence of any NHLBI or TIF recommendations to do so. In the sort of sort of main in around the conclusions. And the main sort of conclusions of this works, inconsistencies exist in transfusion practices in around sickle cell and thalassemia patients in non-sickle cell and non-thalassemia and community-based healthcare systems with regard to the following NHLBI or TIF recommendations. This may be part due to unfamiliarity with the recommendations or reluctance to adapt cost-adding transfusion practices without adequate high quality evidence which supports a reduction in transfusion related outcomes, and there is a potential need for expanding the role of advanced technologies in transfusion management, notably red blood cell genotyping and automated red cell exchange, particularly for sickle cell disease patients, through increased education and education and centralizing use of resource-limited geographic areas. In an expanding world of high quality and cost-effective care, future support, prospective support for transfusion-based multi-center prospective randomized clinical trials, along with implementation science research, is critically needed to determine and promote the widespread utilization of evidence-based practices in transfusion management of patients with hemoglobinopathies. Finally, in around works by Marianne and team in the journal of transfusion from 2018. authors Marianne and team look at hemoglobin A clearance in children with sickle cell anemia on chronic transfusion therapy, and the authors look at chronic transfusion therapy, or CTT, for sickle cell anemia, and highlight how chronic transfusion therapy reduces disease complications by diluting sickle erythrocytes and hemoglobin A HbA containing erythrocytes and suppressing erythropoiesis. Minor antigen mismatches may result in alloimmunization, but it is unknown if antigen mismatches or recipient characteristics influence hemoglobin A clearance post-transfusion. The authors in this works, was carried out by the Children's Healthcare of Atlanta Department of Pediatrics and Hematology Oncology, and Emory University School of Medicine. The research looked to the research or investigators carry out an investigation wherein children with sickle cell anemia and chronic transfusion therapy were followed prospectively for 12 months. All patients or recipients received units of blood serologically matched for big C and small c, big E and small e, and big K, and patients with prior red cell blood with previous red blood cell antibodies had additional matching for Duffy A and JKB and any previous alloantibodies. Patients' red blood cell antigen genotypes determined by precise type human erythrocyte antigen HEA, RHCE, and RHD bead chip assays were compared to genotypes were compared to genotypes of transfused red blood cell units to assess for antigen mismatches. Decline in hemoglobin A from post transfusion to the next transfusion was calculated for each transfusion episode. The authors highlight that 60 patients received 789 transfusions, 740 with hemoglobin A estimations, and 630 with donor HEA genotyping. In univariate mixed model analysis, hemoglobin A was higher in patients with past with past red blood cell antibodies or splenomegaly, and lower within patients with splenectomy. Red blood cell antigen mismatches were not associated with hemoglobin A. In multivariate linear mixed effects modeling, hemoglobin A was associated with red blood cell antibodies. Where with antibodies splenomegaly and negatively associated with splenectomy. The authors concluded that hemoglobin A decline was increased among sickle cell anemia patients with immunological response with previous immunological response to red blood cell antigens, and decreased amongst those with previous splenectomy, demonstrating that recipient immunological characteristics influence the clearance of transfused red blood cells. As part the authors in this works describe sort of the calculations, the calculations in around post-transfusion donor hemoglobin A calculation, and also look at the post-transfusion hemoglobin A estimations, and also the hemoglobin A decline information, antigen mismatches. Look at antigen mismatches, new alloimmunization events, multivariate mixed effects modeling, in around the sort of discussion. Hemoglobin A, sorry, in around part of the discussion, or overall hemoglobin. The authors are informed that hemoglobin A declined following chronic transfusion episodes in children or peds with sickle cell anemia had interpatient and intra-patient variability over 12 months of transfusion episodes. This variability suggests that hemoglobin A decline is influenced by multiple donor and recipient characteristics, while the overall number of red blood cell antigen mismatches did not have a significant effect on hemoglobin decline. Recipients who had previously developed the red blood cell antibodies and received transfusions with extended antigen mismatching had higher hemoglobin A decline, or higher hemoglobin A decline than patients without past red blood cell antibodies, and decline in hemoglobin A was lower in patients with splenectomy, while 2 patients with splenomegaly demonstrated higher hemoglobin A decline. Immunological and characteristics of immunological and additional characteristics of sickle cell anemia patients or recipients thus appear to influence the clearance of transfused red blood cell, even in the absence of detectable red blood cell antibody or antibodies. This peer review works has a list of references aligned to similar around works published sort of more retrospectively in around similar works as well. And finally, an overall in regard to 5 facts you should know about sickle cell disease, and this is a sort of an infographic, if you like, that is accessible, that is accessible and downloadable, and the infographic highlights that a child that gets sickle cell disease or SCD when he or she receives 2 sickle cell genes, 1 from each parent. A child who inherits only 1 sickle cell gene has sickle cell trait. If both parents have either sickle cell disease or a sickle cell trait, it is important for them to discuss this information with each other and with a physician when making decisions, when making other important decisions. sickle cell disease affects millions of people. So that was in around the 5 facts. Five facts you should know about sickle cell disease. That was number one. Number two, sickle cell disease affects millions of people worldwide and is especially important amongst people who come from and those ancestors from sort of African regions. Point three. Sickle cell disease can be cured for certain patients. So a bone marrow transplant, which involves collecting healthy cells from a donor's bone marrow and transferring them into a patient, can cure sickle cell disease. However, a bone marrow transplant may not be the best choice for all patients because it comes with some challenges. A bone marrow transplant expert or hematologist or transfusion specialist can advise patients about patient recipients about whether or not it is a good choice to have a bone marrow transplant. Point four, anemia. Anemia is a common effect of sickle cell disease, but it can be treated. In someone with sickle cell disease, red cells die early, and not enough are left to carry oxygen throughout general physiology, causing anemia. Infection or enlargement of the spleen, an organ that stores red cells, may make anemia worse. Blood transfusions can be used to treat severe anemia. Point five, a person with sickle cell disease can live a long and a relatively decent quality of life. And more than 95% of newborns with sickle cell disease in the United States will live to be adults. People with sickle cell disease can lower chances of difficulties from the disease and enjoy many normal activities by getting routine follow-ups with physicians, following treatments prescribed, for example, hydroxyurea, preventing infections by taking simple steps, including in and around sanitization, and practicing healthy habits, practicing other important healthy habits, including keeping hydrated, since red cells, the red cell parameters increase negatively in those who are dehydrated. Thus, the red cells or red blood cells in general physiology, and where in general physiology applicable to the general population, red cells have to work harder when individuals or people are dehydrated. So it is important to stay hydrated or keep hydrated, as part of specific practices. This flyer this flyer is accessible. This flyer is accessible from the Centers of Disease and Control Prevention, or CDC, there is a there is also a book publication looking at introduction to blood transfusion from donor to recipient, and there is some information in regard to hematology, immunology, antigen antibody reactions, principles of laboratory techniques, genetics, blood group systems, hemolytic diseases, blood donors, blood collection, donation, testing, and transfusion, transmissible diseases, blood processing components, blood storage and transportation, compatibility testing, transfusion risk and hemovigilance, safety, health and environments, quality, looking at quality around quality and around transfusion, blood transfusion practices, looking at looking at equipment and materials management and indications for transfusion of blood components. This book publication in around introduction to blood transfusion from donor to recipient is accessible and downloadable from the International Society of Blood Transfusion, and the International Society of Blood Transfusion sort of science series was published originally published in December 2020, and again is accessible through the International Society of Blood Transfusion website.